8 fellows, no?
Okay.
Is that next year?
Down the road.
I thought about it. Dr. Merwin, we are live.
All right, welcome everybody. We are at Journal Club, February 28th, 2018. We posted last week, right? Did we post last week? All right, so last week is posted. We are just going to go through the usual Journal Club. We are in Newark right now, and next week we will be at Monarch Education if you want to join us. We had our first education night out for the paramedics, our monthly night out, and that was pretty successful. And we have a bunch of articles. If you have been following us, we are posting them on our website now, www.emsfellowship.com. And we, let's see, what else is new? What else is new, guys? Anything? No? Okay. We're going to go right into Journal Club. You might be surprised that we have Dr. Matthew Harris here, so one of our faculty members. So Matt, as you know, is the only board-eligible PEM EMS doc in the entire world. So thank you for coming, Matt. So he's probably been up like 60 hours, and then somebody has to drive him home or something, right? Or are you going back to work?
Some derivation.
So, all right. So we'll start off by interesting cases, and as things come up, we'll go over them. Who's got interesting cases from last week?
Yes, I have a couple.
Okay.
So I guess for everyone watching, we're introducing ourselves. So I'm Alex Torres, one of the fellows. So I had a patient come in, middle-aged patient came in with sore throat, was triaged to the acute side instead of the fast track side just due to elevated blood pressure, known hypertension, but has been off of meds for a while. Nonetheless, throat exam's normal, vitals are normal, other than temp was 99.8. Patient felt a little warmer than that, but otherwise, pharyngeal exam was normal, airways patent, no edema, no erythema, nothing like that.
All right, so just stop here. Can we just send this guy home?
That's what I thought.
Because you're only presenting the case because something happened.
Yes.
Right.
And
so we're all skewed.
So yeah. So I have this.
But
patient
so far, this guy's going home.
This patient's going home, and then just something. Patient's just convinced that something's wrong, and the throat hurts worse on exam. A lot of pain with neck flexion and extension. So I said, let's get a CT. Vibes were perfectly normal.
So you were getting a CAT scan to look for retropharyngeal abscess?
Retropharyngeal abscess, epiglottitis.
Because he was having trouble extending and flexing his
Correct.
neck. Is that what you're telling me? And
And
everything was soft, like submentally. It was all
Correct. Yep.
So you weren't suspecting like Ludwig's angina and diphtheria, maybe? I don't know.
No. So there's more to look for retropharyngeal epiglottitis.
But his throat was unimpressive.
Yeah, but pharyngeal exam was pretty unimpressive. So came back and had a pretty large retropharyngeal abscess extending into the paravertebral space.
So tell me the guy looked sick or something.
Nope, looked perfect.
Because most of the world would have discharged this guy home with no treatment. So something must have tipped you over. So give the 7,000 viewers something to say. This is what prompted you to get the CAT scan, so they're not going to miss this.
Yeah. So essentially, what clued me in was the patient was just convinced that something was wrong. She couldn't eat, and literally was perfectly fine having a conversation until I started having flexion and extension of the neck, mostly with extension. Just broke down into tears from pain, and that was pain out of proportion. Essentially, is what was kind of threw me off. It kind of clued me into something must be going on, some kind of deep space infection, and got the CT, and then I got the call back from the radiologist saying it was about 1 centimeter by 6 centimeters. Extending down into the paravertebral space, and spoke with ENT. They looked at it and said, yeah, absolutely, it's like an abscess, and that's kind of where we went from there. But the patient looked well, and that patient probably gone to fast track or wherever that patient would have gone home, without a doubt.
So
didn't look sick. It was just someone who's normally awake, talking, looks comfortable, and then I can provoke tears on exam without even touching the patient, just their movement of their neck. That kind of clued me into something.
You just have that effect on people.
Yeah, apparently.
I can't use that role in the PTR.
Yeah, and this like I said, was a middle-aged patient. This wasn't.
So tell me, they just got IV antibiotics and did okay? Set the moral of the story.
IV antibiotics. Spoke with the ENT. They said they were going to give it 48 hours, and if there's no improvement, then they were going to discuss a potential drainage.
Is there any benefit in the adult world to just doing a screening X-ray? So that
No.
same patient would have done a lateral neck.
Because we all know that if we hyperextend the neck, you get a steeple sign for just hyperextending the neck. So so the old teaching maybe 1,000 years ago was to get an X-ray for croup, and everybody stopped doing that, right? Because
but the
it doesn't
lateral
help.
neck for an RPA, you should see some prevertebral thickening if it's a real RPA.
All right, so I'll give you that, but
I'm gonna get a CT to confirm.
so I'll definitely give you that as a good board question. But I'll give you that as a good board question. But I mean, if you're suspecting an RPA, how many people get a screening X-ray first? Because we have to run all of these measurements. I mean, how many people the night before memorized all the measurements for an RPA?
In our neck of the woods, the PTR is probably all of them. Because I think we're a little
So
bit
the
more
PTR is more
sensitive
sensitive to radiation exposure. I'll give you that. But I would say that switches in the adult world, that when we CAT scan, like we take vital signs, right?
I think it is a vital sign.
You probably also have radiologists that are reading your X-rays at all hours, and I think I'm not going to feel comfortable saying there is or is not a PTA on an X-ray. Right, an RPA.
I mean, I bet if I quizzed you guys right now about all the measurements, I mean, you guys just took boards, all the measurements for all the vertebral bodies at every cervical level, you would struggle a little bit, right? I mean, I know I would sharpen up the night before and know like everything, and then I would forget it. And I remember over the years reading lots of books about all these numbers, and you just don't use it every day, right? I mean, anything you can tell us about RPAs in kids, Matt?
They're common. I mean, they're common in younger kids.
What % go to the OR?
Less than half. I think they're become much more about antibiotic than watching.
Yeah. I mean, you ever see RPAs like in babies?
So you can see RPAs in really young kids. I mean, those are the kids who have persistent fever and drooling. We don't see a heck of a lot of epiglottitis anymore. So I tend to think about RPAs and the kids who are just kind of sitting there like this and crying and stuff. I don't want to move their neck at all. If you move their head down, they do absolutely fine. You move them any other.
But that's the easy thing. If a kid comes in like that, you just say, why wouldn't the doctor have gotten a scan of the neck, right? But if you're getting a scan of the neck by an X-ray and the X-ray is abnormal, you're scanning, right?
Right, but if the X-ray is normal, I probably am not scanning.
So then the question is, what % of kids have X-rays that are normal looking and yet have an RPA on CAT scan? And I bet that number is frightening.
Yeah, so I'll answer your question. The question is that the issue is that in kids, I imagine it's probably the same in adults, is that your lateral neck is very much dependent on the extent of flexion or extension that it's in. So if it's not, I mean, not to sound like an orthopedist, but if it's not a true lateral, not hyperextended, you can definitely miss it.
And I also bet that if a kid wound up in a community hospital and even if somebody was smart working, they would say, how often do I look at babies' necks, and this kid is not moving their neck well. Even if the X-ray looks negative, they've already probably decided beforehand they're getting a CAT scan of the neck.
Which is right.
Because you miss an RPA, you could have a bad outcome. You call an X-ray normal in a kid who can't move their neck well, that's a high risk.
It's like you're advocating for there to be some sort of specialty in pediatric emergency medicine.
Right. Right, but my guess is if your pretest probability is high enough, if your X-ray looks fine, you're still getting a CAT scan,
Correct.
right? So,
I would say it's more used to screen out than to screen in.
So it's some kid who you're in your gray zone, right? You go, I'm just not sure, but this is just going to help tip me over to nothing's wrong. I'm sending you home. All right.
This is kind of like sort of like the SBO X-rays. I know people do this all the time in the same realm, kind of. Which, I mean, there's really not much utility, I think, for them, but people are doing this all the time. For someone who's coming with abdominal pain, they suspect there's an SBO, and we'll say, or maybe we'll tip them over the edge one way or another to pursue further imaging.
Right. I always say the only person I get an X-ray on the ER is somebody who I think might have free air, because then my workup will probably stop, and they'll go get an X-lap, right?
Yeah.
That's it. I mean, if I suspect a bowel obstruction, I'm going to get a CAT scan, right? If I suspect most anything else, I'm getting a CAT scan. But if it's something where my workup can stop based upon the plain film, then I will do it, like free air under the diaphragm. But I mean, that's it for me. Everybody else, I don't understand. If you see, I mean, I've gone to journal clubs where people say, how many air fluid levels does it take to call it a small bowel obstruction? And the answer is, nobody knows, right? I don't know if there's any good definition of that. And you don't always have the old X-ray available. And I don't know, what do you guys think? When do you guys order bowel
I never
plain
do.
films?
I never do, but I see it done all the time.
But what about somebody who's like terrible peritoneal signs, then they suddenly got better, and you think they might have perfed? Do you do it then?
Yeah, I mean, you can always do an upright chest and see if there's also
if you can
free
get
air
it
that
faster.
way.
Sometimes just pushing for the CT and making it happen is
I think there's
faster of the two.
I think there's a utility in getting an obstructive series basically prior to, just because you know there's going to be a 2 to 3 hour delay. And in some facilities, it could be even longer before you get a CAT scan and the read. So if I have something that's grossly abnormal, I see completely dilated lips and bowels, now I can get surgery on board 2 to 3 hours sooner
That's exactly
versus
what I was
later.
gonna say. Surgery would
So
be on
it's
sooner.
just earlier, specialized care it's something that's clearly visible on a plain film.
But we know most SBOs don't go to the OR. Most SBOs resolve, with an NG tube. And believe it or not, some people can actually get better without NG tubes with small bowels.
But then I do have
Because
that-
sometimes we call things small bowels, they're really ileuses. Sometimes we call things ileuses that are really small bowels.
Yeah, ileuses are overread as small bowels. But what about the patient? You may think I'm a bad doctor for doing this, but what about the patient who comes in and says they have abdominal pain? They insist on getting a CAT scan. So you go through and you explain, we don't do CAT scans on everybody. Really, I have a well-rehearsed speech, but they are insisting. And I say, well, maybe we could just snap a quick X-ray of your belly and make sure everything looks okay. And then they go over and we can confirm there's no free air, there's no emergency here.
Right.
If this gets worse, make sure you come back. Is that
Right.
bad medicine?
I don't know. It's not bad medicine until they go home and
Silence in the room.
it's not bad medicine until they go ask their friend about this. They go ask their friend about what the ER doctor did, and the ER doctor said, this, and this friend goes, what?
Because you don't want to expose. I mean, the amount of radiation is considerably more in CAT scan. Not that it's concerning if somebody's, really having a surgical emergency, but also, the time in the ER, the resources, all that kind of stuff. If you just get a quick X-ray, it's like offers some level of comfort, I think, to the patient.
Yeah.
Not really myself, because it doesn't really add anything to my diagnostic work.
Right. I have a line. I say, listen, we only figure out belly pain 25% of the time in the ER. We could be back here in 5 to 6 hours after your CAT scan is done, with nothing much on the CAT scan. And if that's if that's what I tell you in 5 or 6 hours, this is good news. So we're probably not going to figure out what's causing this. But again, 5, 6 hours, you're going to be waiting here while we let the whole contrast go through all your bowel. And then we'll take you for the X-ray. Somebody will read it. It'll take a long time. And if I can't tell you what's wrong today, I want you to start thinking that is good news. Because people go, then why don't I come to the ER, blah, blah, blah. I don't know. What do you guys do? And that was some
tell you
big.
what you don't have instead of what you do
Right.
have.
That was a big study where we figured out belly pain 25% of the time. And it's usually either gas or we don't know.
Right.
And I think setting expectations definitely helps because people just don't know. They don't know. They see these TV shows and I
Right.
thought I was going to get my thoracotomy in the first 3 minutes.
Right. Yeah. Haven't you guys ever had the worst belly pain of your life?
Yes.
Yeah. Oh.
Yeah. And you didn't go to the hospital, did you?
Nope.
Although we're not going to tell people not to go to the hospital. But one day in your life, you have to have the worst belly pain. One day in your life, you have to have the worst headache of your life.
You guys should know that the abdominal pain resolves after fellowship.
No, that's just a GI bleeding. All right. Anything else with this case?
In that case, no.
No.
I ended up getting 3 days of antibiotics. Switched over to oral antibiotics. Difficulty swallowing improved. Was able to tolerate oral.
Yeah. Any steroids?
No.
Not any steroids for kids with RPAs?
No. Steroids, it's interesting. Steroids have come back in fashion for kids with pharyngitis. There's a good study from last year that looked actually both for viral and strep, and even surprisingly more so in strep, that there's a quicker resolution of symptoms. I mean, not shocking, steroids make everyone feel better, but in viral pharyngitis and strep pharyngitis, and in kids where the dehydration is a bigger concern than the infectious process, seeing a shortened duration of symptoms instead of
Yeah,
symptoms.
I've been doing it for years. There were 2 studies in the 80s that I used to quote, and then now there's all more recent studies. But they both said that steroids are good. It's just oral prednisone in these 2 studies, and both of them were only anything more than 2 days didn't add any benefit.
I do Decadron.
Decadron's easy because
One-time dose.
you give it oral or IM.
Well,
Yeah, if they can swallow pills, and if they can't, you can.
right, and then honestly, anecdotally, I think IV Decadron works better. So if they're getting plugged in, I wouldn't do it. Wouldn't a line in for it if I'm putting a line to give some fluids.
But I thought oral Decadron tastes bad.
So it's interesting. So the IV solution of Decadron can be given orally, and that's in a dextrose solution. And it's more concentrated. So oral Decadron tastes disgusting, but the IV solution, which is 10 milligrams per ml, can be given very easily and very quickly.
And you mix that with something?
No, it's 1 ml. Yep.
You just squirt it in the back of the mouth.
Yep.
And well, that's interesting.
You
But I thought
you didn't notice the numerous vials of Decadron missing from my drug box last year because my kids all had pharyngitis.
he's kidding. He's kidding. But doesn't Orpred taste okay? What flavor is Orpred?
Like gross. I don't know.
Orpred tastes gross? I thought Orpred tasted okay compared to Dextron maybe.
We can have a tasting contest.
All right.
Bioavailability is the same though.
Yeah.
I mean,
The
for
vast
Decadron.
Decadron
Way,
was-
But Decadron used to be that it was a lot of volume to it. Isn't that the way it used to be?
Right, so that's why we all switched to the IV solution to be given PO.
So
And actually, when you order it in our system here, it comes up as
There comes up as
IV
an
to
error
given
actually,
PO.
yeah. But
So
it's
you
an
order
IV.
it IV,
It's
and
an
then you
IV
tell the
order.
nurse to give a PO.
Yep.
Well, in the PEDS order set, there actually says IV for PO use.
Really?
Yeah.
Yep.
Huh.
That's what it comes up as. Nice.
Yeah, we used to, say one of the children's hospitals that I worked at, we would get the tablets, the Decadron
Crush
tablets,
them,
and just
yeah.
crush them and put them in whatever.
And then you send them home with nothing.
Yeah.
And they send them home.
I had an interesting hematologic case actually. It's,
Pre-hospital?
No.
All right, go ahead.
So a young person with sickle cell was sent to visit family in Port-au-Prince in Haiti, which we're all very familiar with from our trip last year. While in Port-au-Prince, had a vaso-occlusive crisis. So did what one does and goes to the hospital there, where they got some labs, and the kid was anemic, so they gave blood. And 12 hours into blood, the kid spikes fever of like 104, and starts getting sort of a rash on the belly, rash on the chest. The grandmother who's with the patient sends some pictures to mom, who's in New York. Mom thinks the kid doesn't look great, hops the plane to Port-au-Prince, runs to the hospital, signs him out, and shows up to Port-au-Prince airport with this febrile kid with a diffuse rash. And kid gets on a plane and flies to New York, and at JFK getting off the plane, somebody said, "Man, that kid looks terrible." Called an ambulance, and they showed up to an institution that I work at in New York. And the kid looked terrible when he came into the ER. Was, I think 9 or 10 years old, 70 over 30, heart rate of 150. And the fingers were dark and black, and there was purpura everywhere.
Were they peeing black?
Kid hadn't urinated in a day, so I'm not sure. But febrile, looked terrible. Hemoglobin was 4.2. Platelets were 10,000, and I forget what my count was also. So pancytopenic, and looked terrible. And the fingers on that were I'd say maybe seven of the 10 fingers were just black in the periphery. So your diagnosis is, what do you think? This kid,
So the hemoglobin was 4. What was the rest of the blood work?
my count was 5, platelets were 15 or something. And the kid was febrile and horribly ill-appearing with a diffuse purpuric rash. Right, so meningococcemia is definitely something very, very high on your list, right? You could get a blood transfusion in a third world country. So in the end, this is actually purpura fulminans.
So did you put the kid in isolation when they hit the door?
Yeah. I mean, this was a kid we literally saw in the ambulance bays and right to that room. And so, we're concerned for purpura fulminans. And so Vanc and stuff. It's actually usually strep more commonly than meningococcus.
Right. But it can be other things, but more
Yep.
commonly strep.
And so we did, I think we did Rucephin and Vanc, and the kid went to the unit.
Cytocortef?
He did not give Cytocortef, not give steroids to the kid.
I
Actually, this is
mean-
the only time I've seen a hematologist come in overnight.
In retrospect, would you have given?
No, I don't think there's an indication in purple fulminans for steroids. But unfortunately, the kid's not doing terribly well, which is unfortunate. But it's a very impressive clinical picture. And then because meningococcemia was a question, and this kid looked horribly ill-appearing, and just on a plane with 250 people, we had this big question of do we notify
I mean, I'm thinking
the
about.
CDC?
What am I thinking about? Wiskite-Aldrich syndrome. Is that what I'm thinking about? Well, I mean, what's the adrenal crisis with?
Frederick Waterhouse.
What has Friedreich's syndrome? Right. So that you have hypertension, potential meningococcemia versus strep pneumo.
Right.
I mean,
It's probably not. It's probably
adrenal
not
failure.
wrong. Yeah. I mean, he wasn't in he never made it on suppressors, so he wasn't like in. So I give steroids if you have press or refractory hypertension, but it's probably not wrong. It just wasn't.
So,
I don't know.
so you can think of antibiotics. I assume the kid has severe hemolysis. So the LDH was abnormal.
Right, and so these are the kids actually that you don't want to give blood to, right? Because they're just going to hemolyze and get very sick in front of
So the hematologist came in to perform smear to look for schistocytes?
Yeah.
Right. We could have done that. But, all right. They could do it better, probably, I guess. So, so the hematologist came in to look for,
Really more to guide the care. Purple fulminans is pretty rare.
TTP?
Sorry?
Or MAHA? Like the microangiopathic hemolytic. So it's
I mean, these are all
hemolytic anemia,
hemolytic,
which is
yeah.
MAHA versus. The kid was febrile. The kid was altered. The kid had a low platelet count. And the kid sounds like
Certainly
TTP.
could be TTP. Sure.
Yeah.
But TTP doesn't give you the same clinical findings as purple fulminans. Purple fulminans is like a vascular phenomenon that looks awfully like the worst endocarditis you've ever had. You just have these. It's not because it looks like you have septic emboli, because it tends to be in like the fingers and the toes, but it's actually really more of a vasculopathy than a
Right.
septic.
The
emboli.
chest X-ray.
Oh, it's okay.
So septic emboli plus carotiary lesions on chest X-ray. Right. So, yeah, I mean the kid.
Very sick.
Not
So it's
doing
still
well.
very sick. Yeah.
Yeah.
Very, very interesting.
Yeah.
But I think the key is don't get a blood transfusion outside of US.
Yeah.
That's interesting.
So we've had a few comments just based on the cases that I'll just read. So Bill Onago is watching. He said they don't regarding CTs. They don't use contrast, oral contrast at all for any CT studies, or not even obstruction or anything like that. All the radiologists are comfortable reading it.
So this is so Bill's in California, right?
Yeah.
So he doesn't give oral. So Bill's at Kaiser Permanente, right, in California.
I believe so, yes.
So they don't give any oral contrast for on appies. Is that what he's saying?
Anything.
At one of the hospitals I
No
work
oral
at, same thing.
contrast for
No
any
oral
CT
contrast for
study.
anything, with the exception of recent, like bariatric surgery or something where you're like there might be micro perforations from surgery.
We'll do a quick swallow for duodenal trauma.
Right, but
That's
that's
it. I mean,
otherwise.
you can see the
IVL
appendix.
is-
And by the way, that may be one of the only indications to do it, and that's still like
Not a great,
that's a great like debate. Should
Right.
for duodenal trauma, should we do it or not? But I mean, what about like diverticulitis?
We didn't do it.
They,
We're not trained
the
yet.
radiologists feel like they can read it well enough and see it with just
With
like
IV
contrast.
And do you
you'll
happen
see
to
the
know
streaking, you'll see-
what?
With IV contrast, you'll see the streaking. You'll see the.
Do you happen to know like how thin their cuts are though?
It's the most recent generation CT scanner, so I would imagine very high resolution. I don't know the exact slides of the
Okay, I
cuts.
don't remember. We had
So your hospital no oral contrast ever?
the only time we ever did it is if we were scanning someone under age, so it was under age 16 that had a BMI less than 25. That was their.
I would think you would use a BMI more than you would use
Yeah,
probably
they
like
were
every-
bigger on BMI, but
Yeah,
like,
if you're
So
thinking
your,
for-
your point, by the way, is that fat is intrinsic contrast medium,
Correct.
right? So actually, the CAT scans that are hardest to interpret are the ones with very thin people,
yes.
and the overweight people are the easiest because they have fat, which acts as intrinsic contrast medium.
Yeah, and then for some of our, like for our diverticulitis patients, if we were really, if it was gonna be a battle back and forth with radiologists, some were easier than others, but, they would do rectal contrast over oral contrast.
Right, and
every
who did the
day of the
rectal
week.
contrast, the ER or radiology?
Radiology.
So say this again, so if your BMI is less than 25, you were giving oral contrast.
We were but patients over age, I believe it was 16, over age 16 that had a BMI of at least 25.
So
we would
Bill,
not
are
give
you
oral.
telling me that at all of Kaiser Permanente in California, this is the whole policy for the entire system in California?
There's about a 12 to 15 second delay, so I'll let you know when he responds.
All right.
I can tell you the reason that ours came into play. It was because it was all about ED flow. It was the oral contrast slowed us down. First, we went
Yeah.
from barium to all gastrographin for anything, and then we went, why are we even doing gastrographin? And there's a good amount of, especially radiologic literature, that if you have new generation CTs and you have high resolution images, you can see all the important stuff.
So what about then IV contrast? Were you waiting for renal function to give IV contrast?
Never.
Never. But what if it's
Unless you were like a unless you were
Don't say the
not
dialysis
dialysis,
thing.
not dialysis. Unless you were somebody that they stated, I have known poor renal function. I'm waiting to working with my kidney doctor. Okay, then if you had some strong clinical clue, you might, or maybe to reach out to their nephrologist to, can you tell me more? But 90%
in radiology, and they would just scan the patient without a renal function.
Hmm.
Wow.
well, you have
Just
to keep
like
in
we
mind
do
that-
in trauma and
Right.
many of our other
So if I
sick
order a CAT
people.
scan on you today and you go to an outpatient center, they'll be checking your renal function, right?
Right.
And that's the standard,
Right.
right? I mean, have you guys ever had a CAT scan?
Yeah.
Matt, I know you've had a couple.
Several.
Did anybody ever check?
all after fellowship.
So
But fellowship was
we
great.
don't do this on
Yeah.
people, right? We don't. When you go
Right.
for an outpatient,
Right.
I mean, so I was looking at the American College of Radiology, the appropriateness criteria that they publish in terms of what you need, radiologic procedure, what you're looking for. So just looking at right lower quadrant pain, suspected appendicitis from them, it says radiologic procedure, CT abdomen pelvis with IV contrast, and gives a rating of 8, 10. 7, 8, 9 is usually appropriate, 10 is you must do, but nonetheless it says oral or rectal contrast may be needed depending on institutional preference, but it's not an absolute. The only thing is CT abdomen pelvis with IV contrast.
So let me
The right
just
lower quadrant.
let me play devil's advocate. I've heard an experienced radiologist say to me once, when the residents are reading after hours, if the attending's not overreading, they need residents need all the help they can get, and sometimes that oral contrast gives them the help. Is that
Right.
reasonable?
It is if you need.
I've heard people say that. I've heard people say when I'm reading as a experienced radiology attending, I'm fine without it. I know what you're thinking. You're
So
thinking is have experienced people read it.
The bigger question is, should we be making full diagnostic decisions based on only resident reads?
Send that people
That's a
home.
good complex question.
Right.
And
We should
Right.
get them up here and see.
I don't.
Right. So, Matt, what are you doing with oral contrast for kids?
For belly stuff or for
Yeah, for belly.
I think it's more common that we're still doing oral contrast, though. It's not uncommon that kids can't tolerate the oral contrast, and what we used to do is put in NG tubes to give it, and I think parents are appropriately very hesitant to do that. So
But now we're saying you don't have to put an NG tube, but you don't have to give any oral contrast.
right. So as I say, as our radiologists have made the argument that Drew has made is that we get we're a big trauma center, so we see lots of abdominal CTs that have no oral contrast, where they say no free fluid, normal appendix. So if they can see it in their quick trauma CT, I think it's appropriate to do. If the kid's not tolerating, I think it's still the preference of our radiologists to do it. But we get plenty of normal CTs without oral contrast.
I mean, Josh, when you trained, did you give oral contrast?
Yeah. We did.
And Alex, you never did it?
We did in those certain populations.
In that population?
Yeah.
So that meant that many kids, because they were under 25, other BMI was under 25, were getting oral contrast.
Yeah, we obviously for other reasons.
So maybe that's why it's not completely falling out of favor in pediatric hospitals. On the other hand, if you get a big kid who's over 25 BMI,
Which is becoming
I think we used 16 because that's where we start seeing the bigger adult size.
But when we say a big kid, I mean, if that kid was small, yet had a lot of truncal obesity, that would be good enough. For, you know what I'm saying? If the kid was like,
the problem is that there aren't. This is going to be a naive statement, so I can't back it up with evidence. But there probably is not enough data with scale to say, we're not calculating. Maybe we should. We're not actively calculating BMI in kids frequently. I mean, I could say it a few times we do in the ER as if we're pulsing somebody with steroids. But that's pretty much it. I mean, typically kids get a weight, they don't get a height. Most medications aren't height-based in peds.
But we did a study that we looked at BMIs for intubations, looked at difficulty intubation, and we found that 50% of the time when doctors as inpatients order BMIs, it does not get done.
Right.
50% of the time. Right?
To end Mike, I think was where the answer to the question about do they do it out in California, the response was never heard anyone use oral contrast for anything since he's been there.
Oh, Bill said that?
Yeah.
Even duodenal trauma?
I don't know what this is.
Bill, even duodenal trauma?
Question mark.
All right. Other interesting cases?
I had that patient that came in with this patient with a history of severe heart failure, heart transplant, falls with heart failure on an outpatient.
Is this the guy that supposedly coded 3 times in the driveway?
In the car, yeah. So chest pain, then had multiple syncopal episodes, essentially unresponsive episodes where he'd become cyanotic, and then all of a sudden, a few minutes later, would go right back, would be awake with no deficits. In the emergency department, get him set up, and he was awake and talking to the nurses. They were getting him set up on the monitor, and he just had another unresponsive episode. He never became cyanotic, but he was unresponsive, never lost a pulse. Finally get him on the monitor, he's got a complete heart block, wide QRS complex, heart block rate in the 20s, complete heart block. Don't know any history other than chest pain and history of heart failure.
So the first drug you gave everybody at home is?
Calcium. We gave 1 gram of calcium. We got an IV in him within
empiric
seconds.
treatment of hyperkalemia, which might save his life.
Yeah, and then the resident ended up giving 0.5 of atropine before I got in the room to stop the atropine, but nonetheless, I looked up at the monitor, and it was now neurocomplex with a rate of 7. Got a 12 lead, and he was now in normal sinus rhythm, a first degree AV block, but I mean, that means nothing.
So was that
otherwise.
after the calcium?
That was after the calcium. Potassium came back at 4.3. But
it was in close proximity to the atropine.
Correct. So, yeah, it was absolutely a complete heart block. The heart failure attending happened to be in the emergency department seeing another patient, so I had him look at it, and he was like, "Oh, what was the potassium?" And I said, "That was our first thought too." We ended up giving the calcium, and I said, "Here's the repeat EKG, sinus rhythm with a rate of 70. And it was never hypotensive, but didn't have another episode for the other 2 hours while in the department waiting for CCU."
So what we're saying to everybody at home, what you said over and over, is if it crosses your mind give freaking calcium chloride. Who really cares, right? If you don't know the potassium, give calcium chloride. Anybody who's bradycardic, that's new onset, give calcium chloride. If you're wrong, it's okay. If you're right, you'll save somebody's life, and you'll save somebody in the ER, you'll save a cortisone transvenous pacer.
Yeah, and that's what the residents were getting set up to do that. And I said, before we open anything, let's look at the monitor again. And the monitor was 70, sinus, neurocomplex, everything fixed. So we don't need to do a transvenous pacer.
I mean, my teaching's always been that if I get somebody with a complete heart block and they are bradycardic, like significant bradycardia, I put a cortisone. And when they drop their pressure, I float facial wire.
Yeah.
And this way I the cortisone. Is that what you guys were always taught? So
Yeah.
Cordis goes in for complete heart block with bradycardia, symptomatic bradycardia, right? And then pacer gets transverse pacer gets floated when you drop your pressure.
You just have to make sure the cordis is the appropriate size for your pacer wire. Sometimes if you float a cordis that's, what are they standard? Like 7
9
French?
Yeah, 9.
9 French, and it's a 7 French system. If you put the pacer wire in a regular cordis, it leaks out.
So unfortunately, like the kits don't mesh, like the regular cordis that we have
Right.
for trauma.
So you can just put your pacer cordis
What
in.
I typically end up having to do is I have to open up a sterile kit of the TVP kit. So what you have to do is then, if you open up and just put the cordis in, now you have the entire TVP kit that can be wasteful because it's not sterile. So I usually, what I do is I actually go ahead and feed in the cordis, and I actually float in the first part of the actual TVP wiring, but it's not all the way in, and I have the entire sheath over it, so it's completely sterile. And I leave that in there, and then if we need it, we can actually advance now the TVP wiring, or the wire, into the patient if we need to actually paste them, but
Yeah,
without
you can-
wasting
you can-
any of the equipment.
You can connect it so that the wire doesn't have to go into the cordis. Yeah, and it leaves
Right.
it sterile. You can leave it just sitting.
And you can completely leave it sterile, but it still has to be connected.
Yeah.
Otherwise, you're going to have to open up 2 TVP kits at the end of the day if you just only put the cordis in and leave it alone.
I see. I mean, you work full time nights. How often do you put a floated pacer wire?
I've probably done it twice last year. This year, nothing.
That's only February.
Yeah, it's only February. I'm sure we'll get something.
I did.
Maybe tonight.
Yeah, maybe we can have it tonight.
Yeah.
You'll get a few here.
Yeah, and that's what I mean. We were very close to putting it in the other.
Yeah, you'll do a few here. Right?
Yeah, we were very close to putting it in, but I mean, once the guy went into a sinus rhythm and is awake and talking, he was normotensive. There was no sense in doing this. And then,
I mean, he was complete heart block, was tropes negative.
Tropes negative, everything.
And he was not on a transplant list.
Not any longer. And then he ended up, heart failure saw him in plans to put in a biventricular pacer, permanent pacemaker. But I mean, throughout his stay in the ICU, he never once had another episode of unresponsiveness, bradycardia, remained in just the first degree block. Was otherwise fine, but he got the cordis and was ready for TVP.
Why'd that happen? Why did he have like 4 episodes in close proximity? He gets to the hospital and he has no more.
Calcium. I honestly don't know. But he did have an episode. I mean, in the emergency department,
Right.
he had a witnessed episode, and then immediately once he had that episode, we were putting him on the monitor. By the time the monitor was he was actually connected, he was awake and talking, with no deficits, but he did have a complete heart block with a rate of about 28.
I have to give you a very quick, interesting heart block story. About a month ago, in the institution here, a little baby was brought in as a birth at home, and came in not looking great. Didn't require much for labor resuscitation, not great, but was bradycardic. He's got a little bit of some chest compression, some bagging. Heart rate came up, heart rate went down, heart rate came up and down. Goes in the monitor, is in 3rd-degree heart block. It's the only 3rd-degree heart block I've ever seen in kids. And kid goes to the NICU and is absolutely fine. Mom's on the adult side, and mom has a petechial rash. That's the last I heard of it until a couple days ago. And the follow-up for mom is, what's mom's diagnosis? He gives a kid a 3rd-degree heart block. Mom's had like joint pains on and off for a number of years, never really been investigated. It was petechial in the ER downstairs. And apparently there's a bright doctor upstairs who feels that. Lyme definitely can cause heart block in kids in active Lyme, but in parents and moms specifically who give birth, obviously, but joint pains and thrombocytopenia.
Rocky Mountain spotted fever, ehrlichiosis, borreliosis.
So here's a non-infectious cause.
Oh,
And the great masculator
Syphilis.
Lupus.
Oh.
Yeah.
The mom ended up, so they ended
Really?
up making a diagnosis of lupus in mom based on the kid's
Lupus
third degree
nephritis.
heart block.
That's one of the 5 stages of lupus, is it?
Yes.
Hmm.
So, Bill, the patient was not on calcium channel blockers. Alright, sorry.
All right, let's do the articles. Atlantic.
Yeah, I can talk to somebody. Yeah, I just have to turn up my microphone because
So, is this the only trial we have on pre-hospital prevention now?
The Atlantic trial is the only one that I know of.
Right, 'cause
All of
there
the
were 2 studies
cardiologists who are
before.
watching, maybe they might be able to challenge
But there were
I'm
two-
gonna excuse myself for a word.
Okay, there were 2 pre-hospital studies before this on Berlinta, and both said it doesn't work.
Right. Alright, I'm just adding the images so people can see what article we're talking about. So we're just looking at the Atlantic trial, a certain subgroup of those patients to see if there was, here we go, thrombus aspiration, to see if that had an effect on those who were in the Atlantic trial, and also in association with Brilinta or ticagrelor administration. And as we always say, we do not endorse any individual drug product or anything in this fellowship. So, all right. So this Atlantic trial, I have to be honest. This so what we're looking at now, you can see on your screen, thrombus aspiration and pre-hospital ticagrelor administration in ST elevation MI, and findings from the Atlantic trial. So I have to be honest. This trial was. Parts of it were a bit over my head. I was doing a lot of research in the cardiology literature to kind of get an understanding of TIMI flow, TIMI bleeding risks, all that kind of stuff. I've heard of it before, and I'm sure my preceptor would be very disappointed I don't remember it from medical school, but it was just a lot of refreshing. So this was basically the Atlantic trial. When was that? When was it even published? I can't remember. Not too long ago now.
September.
Yeah.
September
2016.
It's been a couple of years. right?
2017. To submitted
Yeah.
June.
That
12th.
this
Oh, this
follow up
one.
was
Oh, okay.
yeah 2017, but the whole Atlantic trial data came out in 2016.
Yeah.
And essentially it was looking at a subgroup of patients who, as I mentioned, got thrombus aspiration. Now, just a little background, thrombus aspiration, as far as I understand it, is relatively new in the field of ST elevation MIs, right, of STEMIs, because traditionally, probably what we're all most familiar with is STEMI goes to cath lab, gets angioplasty, gets a stent, maybe, and is out of the cath lab with or without success. The theory is, if you think about a thrombus being lodged in a vessel, if you're going in and pushing that forward or breaking it up even with angioplasty traditionally, the thrombus can go into the distal part of the vessel, downstream shedding, and you can potentially cause an even larger area of ischemia. So you have worse, post-cath ischemic cardiomyopathy. That's a bigger risk. I know this thrombus aspiration, while new, has been showed to be pretty favorable in the data in terms of preventing a larger infarct size. And from what I ascertained from this study, now it's being used as kind of a rescue or really big MIs. So these are sicker patients who are getting it, and they tend to be younger, and they tend to be patients who we really want to get that clot out of there because they have a long life ahead of them. Potentially they could, live and prosper. So that's a little background of all of this. So basically the point of this study we're reviewing is to, both of these potential treatments, the thrombus aspiration, which they call TA, and then the pre-hospital ticagrelor, they're looking at both of those together and evaluating the potential benefit of them together, their synergistic effect in these patients, and that's what I took away from this. So if you're familiar with the Atlantic trial, we're focusing on ticagrelor, and I can never say it, so don't make fun of me, and out of the group of patients that they looked at, there were 941 that this study looked at. All of those patients got thrombus aspiration, this new invasive technique. So if you look at the Table 1 data, essentially age, demographics, aside from that, as we mentioned, the thrombus aspiration group was significantly younger. There wasn't too much in terms of statistically significance between the two groups. One thing they did mention is, so TIMI flow grade, anybody remember that?
Vaguely.
So TIMI flow is basically from 0 to 3, I believe. 0s and 1s are bad. 0 is complete obstruction. 1 is like you have a tiny bit of contrast that penetrates through the clot. And then 2 would be you have distal flow, but it's diminished. And then 3 is going to be full distal flow to where your wire is. So the thrombus aspiration group actually had TIMI flows that were worse. So they were 0s and 1s. They had more 0s and 1s, indicating they were essentially sicker, like they have large clot burden. That's how I thought of it anyway. Let's see. So in terms of demographics and TIMI flow and patients going in, essentially those were the only differences. When they started looking at all of, they did a bunch of odds ratios in Table 2. You can see all the endpoints that they were talking about, like 30-day composite death, 30-day new MI, definitive STEMIs, all of that. Essentially, odds ratios were not different. There were no statistical increase or decrease in odds ratios between the two groups, meaning, as far as I took away from it, there were not any associated improvement in 30-day clinical outcomes out of all these endpoints that they were looking at when both of these interventions were present. That being said, the only really significant outcome that they found, patients who had, let's see, higher risk patients, so the ones who got thrombus aspiration essentially were sicker and higher risk, they were associated with bailout use of GPIs. That was another endpoint that they were looking at. GPIs are like your glycoprotein inhibitors that really are inducing bleeding or really stopping platelet clotting in real time in the cath lab. That's what they throw at people who are really sick and probably going to die. So the TA group got, the younger group and the sicker group got this intervention as they call a bailout more frequently. So that just again kind of says how the thrombus aspiration group was overall sicker, and maybe that's why they didn't see a benefit in clinical outcomes. As I said, a lot of this was over my head, so I had to kind of do some background research, but that's the best that I understood it. Anybody have anything to add? It's kind of.
So what's the conclusion here? So all these p-values weren't really significant, except
Right.
for maybe one. They came to the conclusion that this was a good thing.
Yeah. I don't know really. So they came to the conclusion, right, that there were essentially no differences between the groups. I don't know why that's implying it's a good intervention.
So their conclusion was thrombus aspiration when left to physician's discretion was used in high-risk patients, was associated with bailout use of glycoprotein 2B3A inhibitors, and TIMI major risk bleeding. Okay, we agree with that, and had no impact on 30-day clinical outcomes. We agree with that. Conversely, pre-hospital Berlinza treatment predicted lower 30-day rates of ST or new MI without interaction with thrombus aspiration. Pre-hospital.
So that's what the Atlantic trial was studying. That's what they took all these patients from, pre-hospital versus, ticagrelor versus giving it directly when they reached the cath lab, and there was no difference in outcomes between those two groups.
Right.
So it doesn't matter when you give it; it's just give it.
So should we give it?
I mean, I don't think it matters when you give it. If that's what the Atlantic trial showed, you give it to them as soon as they roll in the cath lab. There's no difference in giving it in the ambulance. So pre-hospital, I don't really see any benefit. There wasn't even a benefit in patients who are getting thrombus aspiration. That's what this study showed. I mean,
So what about if you're a long way away from your cath lab and it's 2 hours between presentation pre-hospitally and the cath lab?
yeah, I mean, that might be something to consider. At that point, though, are you licensing them? Are you giving TPA and
Right,
then
but
getting
I
the
mean,
CAT
TPA
lab?
is not readily available everywhere hospitally, but Berlinta could be. I mean, it's the only thing that even if you do that, maybe if there's a cutoff, what's that cutoff? But then again, what's the downside of giving it pre-hospital? It doesn't matter when you give it. What's the downside of giving it pre-hospital? That's what some people are thinking, I'm sure.
Yeah.
So we still don't have any clear pre-hospital benefits. Although pre-hospital Berlinta treatment predicted lower 30-day rates of ST or new MI without interaction with thrombus aspiration. So your point is that may be true, but it still doesn't matter. But when you compare it to in-hospital treatment, it's no different. Is that your argument?
Like I said, these cardiologists, they have their terms and things.
So you think it just doesn't matter where you give it?
I don't think in terms of giving ticagrelor, it doesn't matter when you give it. Maybe if they look at a different group of the Atlantic trial and they find a different population to consider giving it earlier. This one, as far as I could tell, in the thrombus aspiration group didn't really make a difference. So maybe the group that had longer transport times, they would be the ones to kind of focus in on the next study.
Right.
And see if it made a difference.
So that's what they should study.
Yeah.
All right, I'll take it. How about nebulized TXA?
Yeah, I can discuss nebulized TXA, obviously with Mike's permission.
He asked my permission. No, it's okay.
So it's just a case report on nebulized TXA for cancer-related hemoptysis. So basically the question was if you have people who have lung cancer or upper airway cancer can get hemoptysis from the cancers, and there's really no good way to treat it without either intubating people and doing something endoscopically or bronchoscopy. And the mainstay of treatment was basically giving blood products, trying to give platelets or improve their hemodynamics, but it doesn't really help with the bleeding much. So they talk about a 46-year-old guy here who had a stage 4 piriformis sinus and thyroid squamous cell carcinoma. He had bleeding from his tracheostomy site. His was initially stable with the heart rate of 105, blood pressure was 132/83, breathing at 21 times per minute, oxygen saturation of 99%. So doing okay, but he was having small amounts of projectile blood through his tracheostomy tube, and they applied direct pressure to the tracheostomy tube as well as the sternal notch, but the hemorrhage didn't resolve. He kept on bleeding and kept on having more blood that was coming out through his mouth. So his initial hemoglobin was 9.3, platelets were 24,000, and they say he had about 100 milliliters of hemoptysis over the first hour. So they decided to just try nebulized TXA as a temporizing solution because it's been shown to stop bleeding mucosal surfaces. So I guess they've known about Dr. Solomonov et al. Used a bolus of 500. So they put a bolus of TXA through a bronchoscope or aerosolize 500 milligrams 3 or 4 times a day, and that had stopped bleeding. So what they did was they took a 10 milligram per milliliter solution by diluting it, and they nebulized the TXA, and within 15 minutes the bleeding basically stopped. Later on he was bronched, and I think he was also given platelets as well. Later on he was bronched, and they thought that they saw the lesion of where it was bleeding from, but there was no further bleeding. So it's, I think it's just another thing to have in our bag of tricks, at least having to think about.
It's only a case report, but I just thought it was pretty cool. I'm not sure I've ever heard of nebulized TXA before. I guess it kind of makes sense, right? We have all these people come in with hemoptysis. What do you really have to offer them?
Right.
I mean, most people have a little hemoptysis because of the tracheobronchitis, whatever that means, or something.
Yeah.
And it's not TB. It's nothing bad. It's
right. But it's essentially topical TXA, just a different way of applying it topically. I mean, if we're going to put it on epistaxis, or we're going to put it on cuts, and it stops the bleeding. I mean, theoretically makes sense the way that it's working, that it's going to get to where the bleeding is and act as a topical agent, so to speak, and
I mean, I would do this tomorrow if I had
Yeah,
somebody.
why not? I
To
think
avoid
what's the
sedation.
downside, right? What's the downside
Right.
to
So
it?
I'm curious, why not just give it systemically? Do you think there's any difference?
I guess that's a good question. Why not just give it systemically?
I mean, in theory,
I don't know.
the vascular beds of your lungs are probably one of the most well perfused beds of your body, so it should get there.
But I guess if you're giving it to cancer, though, like how well is it going to penetrate to the active bleeding site of where the cancer is? I don't know.
Because the center of the tumor might be necrotic, it might not penetrate well, might not very vascular.
Maybe it's like collaterals that are coming around. I don't know.
Right.
Or do both.
Yeah, we would,
Yeah.
right?
Yeah.
I mean, there's probably no downside to giving it. I wonder, does it? And the question is it going to work faster if it's topical versus
Yeah,
systemic?
I guess it's dose dependent, and my question was how much of it is getting absorbed, because it's a lysine analog. The only criticism really of TXA is giving it in massive doses is it's stimulatory neurotransmitter wise, because it's very similar to glutamate. So in massive doses, people get seizures. You could potentially get seizures, but this wasn't a massive dose. This was
Some people
reasonable.
get seizures.
Yeah, some people.
Yeah, I mean, I would try.
Is there
this.
data out there with topical, like the time to stop bleeding with topical versus
Right.
versus
Well, there's
IV?
one paper that showed no difference if you gave topical plus IV or just IV alone. But that was, I think, for like a wound.
Yeah.
But I mean, I would do this. Sure.
Yeah. Why not? Maybe we could use nebulized TXA for nose bleeding too instead of sticking it up.
Or even for a MAP device, depending on the amount of bleeding.
I mean, to me, if you have a nosebleed, there's something about direct pressure that
Yeah.
seems to make sense.
Yeah.
I mean, for that matter, when you bronch somebody, if you find some bleeding, why not just put some liquid right through the bronch somehow?
Well, that's what Salmanov did. Because they said they did a bolus of 500 milligram per milliliter TXA through a bronchoscope.
And they didn't mix this with saline, right?
Who? Salmanov did. Oh no, Salmanov didn't. In this one they did because it's 10 milligrams per milliliter, so they diluted a gram of TXA in 100 milliliters. They ended up, I think, giving the full gram
What do you have
just
to
over
do that?
45
It's a
minutes.
liquid. What do you have to
I don't know.
dilute it?
They actually said it took them 15 minutes to stop bleeding, but in retrospect, if they used a more concentrated solution, maybe the bleeding would have stopped earlier.
Right. It's all made up, right?
Yeah. I mean, I guess the only reason to dilute it would be to have it last for longer or have more aerosolized particles potentially.
So if you're in a community hospital, you have some hemoptysis, ultimately you need to be bronzed, right? Then this may cover you for the night, so somebody can bronch you the next
Yeah.
day.
I would probably dilute it a little bit. I don't think putting 1 milliliter in is.
Maybe not. I don't know.
Just seems. I don't know if it makes sense, but it seems to me you'll get more particles kind of flying all over the place.
Right. I mean, maybe. Isn't that the same thing with albuterol? That I'll dilute it in like 2.5 milligrams or 3 mLs. I mean, we used to have saline bullets next to the albuterol nabs.
Yeah.
And mix them
I
together.
still have that in one of the hospitals I work at.
Really? And
Yeah, I have to
don't
drop
like-
in a syringe and put the albuterol and then mix
But
them
why?
together.
Why can't you just give it straight albuterol?
Maybe it doesn't go deep enough potentially, or maybe if the volume's not there and.
But I mean, deepness depends upon particle size. You have small particles, you go deeper. I mean, adding saline won't make the size of the albuterol particle smaller.
Some of the nebulizers won't nebulize properly with too low of a volume. So like
Some of the
if I
just
put
get the chair.
so if I
Yeah,
would put
put
in
next door.
albuterol by itself, I would add saline. But if I put in albuterol and isotropium bromide, I wouldn't put an extra saline just because of the volume. But it depends on the actual nebulizer. The newer nebulizer kits that are, of course, a little bit more expensive, it doesn't matter how much volume. So I don't add saline to that. But I think there's also something to be said about putting in some saline because of that just the moisture and the saline itself being in the area helps them to breathe better, just like a humidifier at home.
Right. Alright, so nebulized TXA. We'll start tomorrow, or we'll start tonight. So whoever is hemoptysis.
You should just say a nebulized TXA and ketamine combined and see how that works.
Oh, that'd be cool. So we have to. Alright, so TXA. I'm gonna do it though without saline.
Yeah.
Yeah. So.
Can we do
Yeah.
some on me right now?
So TXA. Alright.
But just before we move on, they mentioned that this was from a tumor, but this guy, even just from the picture, had a trach in place, And so I think it's just a good opportunity to mention tracheonominal bleeding, because that is something that can be easily
right.
missed. And I've had many cases.
So that's a big deal, right? So
Definitely a big deal. So it can classically present with like a small sentinel bleed around the trach site, and then followed by a massive life-threatening hemorrhage. They bleed out and they die right there. And the way to fix it is basically put direct pressure, because that innominate artery is kind of right behind your sternum there, and right near that trach site, and the trach
so
is
that's a big
presumably
question. Watch out for
rubbing it
the
away.
artery around the trach site. Any bleeding around the trach
Right.
is a big time emergency.
Right.
Proven otherwise, it's probably going to be okay. But an artery bleed can
You gotta make
exacerbate.
sure. And I've had someone who came in hypotensive. Everyone thought this was just a nursing home septic special, but I was like, that looks like a little bit of dried blood there. And sure enough, when we tried to like explore, then we saw a lot more bleeding, and then putting direct pressure on it, blood pressure went from the 70s and 80s right up to like 100, 110.
There's a couple of
And
things
it was-
like that,
it was
right?
a bleed.
There's a TNA, tonsil and adenoids, when you get your tonsils out. If you start bleeding, like 72 hours? Somebody's taking boards
53.
recently.
You lose the clot.
So it's 72 hours, right? So,
Yeah.
so anybody comes in with bleeding right away from TNA is usually fine.
Right,
But
right.
if you come in bleeding like it's 72 hours or later, that could be a life-threatening emergency, right? So
Right.
you can put topical TXA, I guess just take like Mavil forceps or something, with
Mhm.
some 4x4s, soak it in TXA and just hold it, right?
I've had that a few times. It looks like a murder movie, you know,
Yeah.
when they come in, because there's so much
And they have to go back to the OR.
They
But
have to
it's,
go back to
it's
the
always
OR.
like the big question is, when did you start bleeding?
The worst kid I had with that was it was classic 72 hours, maybe 4 days later, and he came in just spewing blood out, and so my finger went in the mouth. I didn't have TXA. I didn't know that much about TXA at that time. This back
When was this? When you were
beginning of residency.
5?
I was probably first or second year residency. But basically, gauze finger on the back of the kid's throat like this, holding it in there, and we went up to the OR like that because we couldn't get it to stop bleeding. so
I've had
Please don't
the
bite
same
anybody,
thing. Someone
you know,
came
this is
in
terrible.
just in massive hemorrhagic shock. A young kid, otherwise healthy,
Yeah.
day 3 or so, and it was lots of blood. He was starting to lose his airway. We were intubating him, but as we're getting on the phone with the ENT surgeon, he's like, "Listen, you got to get some straight forceps. Just put direct pressure right back there with whatever you got. Direct pressure right on that tonsil, and then magically really improved the blood
And now you
pressure,
could-
stopped it."
And now you can do the other thing you can
Right.
do is you can push on the carotid to stop blood flow, because some of the carotids run through the tonsils, or they run close
Right.
enough. So people will talk about that in the literature. So it's not very good.
Right.
The other thing that comes to mind is the kid who bites down the electrical cord, like and has electrical burn,
yeah.
and it's a couple of days later. I forget what the cutoff is. It's like 72 hours too. Is it 72 or?
I think it's a little farther. It's like
maybe
4 or
it's
5
not.
days. I think it's not 5 days.
Labial artery
Yeah, I thought it
bleeding
was
is
5
always a
days.
test answer.
Right. Delayed labial artery bleeding in
Yeah.
those children,
Yeah.
right? So, but it's not 3 days.
I think it's 5 days.
Is it
I
5
think
days?
it's 5 days.
So 5 days out, and then when the labial artery stretches back to normal position, then that's when they can sanguinate, not right away. You looking up?
Yeah.
Right.
But that's definitely
now
an
it's
EMS
really-
intervention, right? Life-threatening hemorrhagic shock. Not going back there and messing with stuff, but this person is hemorrhaging everywhere.
Yeah.
Just put direct pressure, just like any other bleed, like fistula,
Now that
or like any of the other
makes
things that
sense.
people die from unnecessarily.
Hey, it's one freaking finger.
I just had a third molar. I literally just extracted not even 2 or 3 hours ago, and I spit. The first thing I did when I got out is I accidentally spit the clot out.
Yeah.
And I mean the amount, okay, granted, and I'm not anticoagulated. I'm not 80 years old on Coumadin or Pradax or whatever, or some non-reversible agent. Imagine just thinking of that in the context of an MVA and say one of my third molars got, I hit the steering wheel and got knocked out, and now my airway is filling with blood because I'm gushing from my empty socket where my tooth was, and I got bits of tooth. In the setting of just having a non-rebreather on the patient, what about just literally just nebuli, I know TXA is not available in a bullet like you would get an actual neb in, but I guess in that case you would just soak some 4x4s in it and a couple mils and just kind of
Yeah.
direct pressure and chomp on it.
I use it in dental hemorrhage all the time.
Yeah, we
It
use it
works
in
really
dental,
well.
or we use it in gums all the
Yeah.
time, right? We use it in any mouth bleeding. Yeah.
Wrigley's is making a new TXA flavored gum.
Right.
For all your dental bleeding needs.
All right, stop.
But I think the direct pressure is important. Ultimately, direct pressure, if you have nothing else to do, that's the first thing you got to think about, and just do it. And wherever, if you can get to the source of bleeding. And, I remember someone came in here and everyone's running around and where's the gauze, where's this, and you forget that the patient's just bleeding out when you're looking for all these supplies, when all you have to do is put a finger on it, and the bleeding stops.
Do I have any reason to believe that you'll have a high risk of seizures because of the lysine and analytic TXA if it's topical or IV? Like,
I mean, I don't know the topical absorption. I think that's what it comes down to. IV, you have direct. I mean, it does cross the blood-brain barrier. It does cross the placenta as well. So I imagine it's actually pretty lipophilic, right? So it should go through the skin pretty readily.
In Europe, there's actually a mouthwash, a TXA mouth. I don't know if it's marketed. Not to my knowledge, here in the United States, but it's. I mean, if it's marketed as a mouthwash for patients who are anticoagulated prior to.
Well, you have pills that they give.
I've even seen crushed up. So it's. I mean, if it's a mouthwash, it's got to be. The absorption has to be fairly decent. If it's just something that they're swishing and spitting out, then.
Okay, let's do the next one. So
to answer the question, 5 to 21 days for delayed bleeding.
So
5 to 21.
Yeah, so it says about 10% of cases, typically about 5 to 21 days after the injury, once you have separation of the maturing eschar.
So interesting. So how do I remember that? That's the same period of time that you can get febrile neutropenia. Usually not before 5 days. Usually not after 21. All right, I got it.
Yeah, 5 to 21.
All right, let's do the how long should we resuscitate article.
That'll be me.
So this is by Fanata.
Yeah, this is coming out of Japan.
And European resuscitation.
Yep, resuscitation. So this is a brand new, accepted for publication January 3rd of 18. So brand new.
Hot off the press,
Hot.
as they say.
Very hot.
Hot off the. Did you at home read this before you turned into Journal Club today? Don't go back. That's fine. Take it as my voice.
So this is again coming out of Japan. I won't go too much into the history or structure of the EMS system in Japan. It is somewhat different than what we have in the U.S.
So once again, the major trials. We reviewed the pre-hospital intubation trials in Japan had a big study, which was done a few years ago, which told us not to intubate pre-hospital, and now the pendulum switched back again. But Japan, because of their IRB rules, has some of the best studies.
Yeah, and they have huge populations for these studies. With regards to, again, we're talking about how long to resuscitate, do CPR in out-of-hospital cardiac arrest. So they actually have an all-Japan out-of-hospital cardiac arrest registry. So they are able to get significant numbers for population studies. So
is that like the CARES database?
Yeah,
So
that's kind of what
Japan's equivalent to CARES?
That's pretty much it. This is they actually have, I guess they have different registries from what I was looking up, different registries for different I wouldn't say high risk, but large, pretty important topics. So they have the out of hospital cardiac arrest registry, they have the intubation, so they're able to have these huge registries for just all cardiac arrest, out of hospital cardiac arrest, ROSC, not ROSC. They also have all the pre-hospital airway studies. So anyone, pretty much from the EMS system, anyone who has any of these what are considered pretty much high-risk procedures done in the pre-hospital setting are entered into a large database, and it makes it easier for them to extract data as necessary for their research. So I think that they're able to just create different registries when they need to, just because all the data is put in a database where they can easily extract information. So again, this is coming out of Japan. They do not have termination of resuscitation rules. So all of their patients who undergo out-of-hospital cardiac arrest and are resuscitated in the field are transported.
So that's silly, right? I mean, we're in New Jersey, if anybody doesn't know. So we've had a TRE protocol since 2006. Right. So Japan needs a TRE protocol. Maybe our EMS physician, Dr. Snow, will fix Japan.
Yep. So you got some big shoes to fill. So again, these patients were all transported to a hospital because it's EMS providers in Japan are legally prohibited from terminating resuscitative efforts in the field. So once they get to the emergency department, physicians can use the resuscitation duration in the absence of ROS to help justify how long they're going to
or continue to resuscitate, or if they're just going to go ahead and terminate. So that's kind of what this study was looking for. What period of time do we say, hey, you know what, we've done it for this long, we still don't have ROSC, I think it's appropriate to terminate efforts. And again, this would be done in the emergency department. So it specifically looks on, I guess all the literature doesn't show any relationship between pre-hospital CPR duration and post-arrest outcome. So it says in out-of-hospital cardiac arrest patients without pre-hospital ROSC, there's no studies focusing on that particular duration component. So they wanted to look at, they were investigating the impact of pre-hospital CPR duration and other pre-hospital variables on the probability of neurologically intact survival in patients who did not have pre-hospital ROSC. So this was an observational study for adults, patients 18 years or older, for whom resuscitation was attempted by EMS after out-of-hospital cardiac arrest. This was a 4-year period from January of 2011 to December of 2014. The only patients that were included in this study were those who were presumed to have a cardiac cause of their arrest, unless evidence suggested other cause, and that they described respiratory disease, CVA, malignant tumors, and anything else that might suggest a non-cardiac cause of arrest. So pretty much it says there's no predetermined amount of time you should be resuscitating pre-hospitally, and they define the pre-hospital duration as the time CPR was initiated by EMS providers to hospital arrival. So they didn't include any potential bystander or CPR duration in this, just because it's, and we talked about it kind of in the limitations, is that it's virtually impossible to get the specific time frame of bystander CPR. Again, looking at CPC scores 1 month later, CPC 1 or 2. When they when they gathered the data and analyzed it, they looked at multiple variables. One of the things that they started with was classifying age into 2 categories, and that was age greater than or equal to 75 or age less than 75. They used the cutoff of 75 years because based in Japan, that is the definition of elderly by the Japan Gerontological Society and the Japan Geriatric Society. So that was kind of how they chose that. They also looked at multiple other factors in the pre-hospital setting, but ultimately they ended up having almost 500,000 out-of-hospital cardiac arrests, 421,000 essentially that were older than 18 years old, and that did not have pre-hospital ROSC. So pretty much out of all the ones who had resuscitation attempted, 85% did not have pre-hospital ROSC, and those were analyzed. Out of those 421,000, the rate of 1 month CPC was 0.45%, so pretty significantly low percentage of patients who did not get ROSC. So they looked at 10 different variables, and pretty much what they gathered was the top 3 higher ranked predictors pretty much that were associated with a 1 month CPC score of 1 to 2. The 3 most important things they found were initial shockable rhythm, an EMS witnessed arrest, and an age less than 75 years. And it says out of those 3 that they found the best single predictor of a CPC 1 to 2 was actually the initial shockable rhythm. The second most important predictor was age less than 75. So when we kind of talk about when you're stacking everything up in terms of what are the likelihoods of having ROSC and neurologically intact survival, getting ROSC does not equal neurologically intact survival, as we can tell. But when you have these, these are the important factors you want to look at in your patients. So essentially what I was looking at was you kind of gathered all of it and you looked at the pre-hospital CPR duration. Essentially, once the probability of 1 month CPC score 1 to 2 got so low that it was less than 1%, was 26 minutes. That was essentially the key here. And that was for patients less than age 75 with a shockable rhythm. So they had all of the features that would hopefully make it a better outcome for them, or increase the likelihood of a better outcome. So, but then they looked at it for patients greater than 75 years with a shockable rhythm. Actually, it was only a 10-minute duration of CPR. So, and then EMS unwitnessed arrest and non-shockable rhythms was less than 1% chance of a CPC score regardless of the amount of time needed pre-hospital CPR. So essentially, so what did it look at? Or what did we finally come to conclusion-wise was that those patients that were less than 75-year-olds witnessed with a shockable rhythm, you can pretty much go up to 26 minutes before it was essentially futile effort. Those that are greater than age 75, you had about 10 minutes. Again, if it was shockable EMS witness, those that had none of those characteristics, it was irrelevant the amount of time that you did CPR. They had a 0% chance, a 0% outcome.
So I weigh this against the study we reviewed maybe 2-3 years ago, which looked at what percent of people who don't get ROSC in the pre-hospital setting get transferred to the ER or walk out of the hospital alive with at that time minimal to no neurological disability. And the number was 9%. It was a number higher than most people thought. So 9% who get transferred will walk out of the hospital alive. That number again is much higher than everybody thinks, because we know that for medical patients you stay in play, for trauma you let them go, right? And look at the variable associated with survival. And it was all stuff that we were talking about, which was initial shockable rhythm, initial rhythm being VF, bystander CPR, and the first rhythm being, well, I said it's shockable. And then, of course, I added end-tidal CO2 greater than 10 to 20 minutes for resuscitation. Has a better chance in overall outcome. This added the age, but it's not surprising that if you're under 75, you probably do better than somebody over 75.
Yeah, and then, I mean, it says pre-hospital ROSC is the strongest predictor associated with survival.
Sure, so it's all the same thing we've always thought.
Yeah.
I mean, did this add anything to our knowledge? They said maybe Japan did it this time, and the previous article wasn't Japan.
Yeah,
we all know we have the same problem. We can't figure out the last step in resuscitation. We have all these people now who have persistent some rhythm with end-tidals of 40, and we don't know what to do. We transfer them to the hospital. They're going to die because their end-tidal CO2 will go down from poor CPR going to the hospital. And if you can't stay on scene or resuscitate somebody for an hour or 2 hours or 3 hours, even if they have a salvageable rhythm like VF. So, is it okay to pronounce somebody in VF? Your end-tidal's 8. You've been working up for an hour. You're gonna pronounce somebody in
How
VF?
old is the person?
Only after double
Alright.
sequence defibrillation and
As
potentially
well?
a beta blocker.
All right, so I'll buy into that. So nobody should die without double sequence defibrillation of being at least one, if not more. I mean, probably early on, right? So that's absolutely true. And beta blockade, your problem with giving beta blockade, because we do have science that epinephrine is the wrong drug to give and beta blockade is the right drug to give in cardiac or defib arrest. Your problem is that by the time you give your beta blocker, they've already had 10 toxic doses of epinephrine. Right? So sympathetics have already surged, so you decrease those sympathetics, and now it's too late. But I mean, I think your point's well taken. Why? Because you're insinuating that if you're 40 years old and I bring you to the hospital, somebody can do ECMO on me. All right, I guess that's an okay answer. But now, if you're 80 years old, you don't know what the guy's EF is. You don't know about wall motion abnormality. The end-tidal CO2 is 40, so you know he's probably got some sort of left ventricular squeeze. But the resuscitation has been an hour, and he's still in VF, and he's never had ROSC for the last hour. So be it that he's 80, he probably will not have good outcome. On the other hand, you have a good end-tidal, you'd be transferring that patient, and it's not so much what happens when he gets to the ER, because even if you transfer somebody to the ER where they can do ECMO, your end-tidal CO2 will go down during transfer.
Yeah.
So what do you do with that? I mean, this stuff happens to us every day. So what do you do with that patient?
And you're gonna have you're gonna have poor quality CPR in the back of the ambulance, all the transitions from the ambulance to the hospital bed, and you're gonna, I mean, in terms of neurologically intact survival, I think it's gonna decrease every time you interrupt good compressions.
Right. So you've been on this in 45 minutes. You want me to, I'm the paramedic, you want me to stay on this scene another 30 minutes?
No, I mean, I think that.
You want me to pronounce?
We can tell you what
I
they do in
agree.
some other countries because we looked at some of these case reports.
Yeah.
And it was England, and we know Paris. They send an ECMO team to this house.
To the
They've
house.
reached this exact endpoint. 30 minutes in, field ECMO to get to the hospital to get them.
And the reason their numbers haven't looked as good as we had hoped is because they were just doing ECMO on a lot of people instead
Right,
of being very
right.
selective.
You have to choose the
It's
right
it's this patient, not all
So it's that
comers.
40-year-old
It's
guy.
that 40-year-old.
But now the guy's 60 years old, and his end-tidal CO2 is 40, and 60 is not old, but he doesn't have the same EF as a 40-year-old. Maybe it's just a guess. You have no idea. You roll just on the guy's heart, but he's in VF, right? And you can't get ROSC. You don't know what to do. You're trying double sequence fibrillation. Maybe it works, maybe it doesn't. If it does work, that's great. You just transfer the guy. But what, you know.
So we have a
If-
question from. Oh, sorry.
If you have a close facility or a shorter transport time, should we be putting on a mechanical device and taking these people straight into the cath lab for this refractory?
Right, so then you have to,
Refib?
you have to
But that's-
maybe,
that's-
then you have to find a cath lab, well, they'll
Right, that's
do a
geographically
PCI.
dependent. And
when you were a
cath
resident,
lab
did they do cath, would they cath somebody
No.
who's on cardiac arrest? Any of you guys, when you were residents, do they cath anybody when you were cardiac arrest?
They still won't do it now.
I mean, I train in a community hospital, and I mean, like you said, getting someone to cath a post cardiac arrest patient can be.
So we do know there are several hospitals in the world that do this, because they write papers about this, right? I don't know if they have better outcomes, by the way, and I do know that every study on mechanical devices, manual wins.
Mhm.
So I do know once I put a mechanical device on somebody, I'm probably going to make somebody worse because I will not do effective compressions when the device is being put on. So I will decrease mortality. I will increase mortality. So I mean, where does this lead me? I mean, even that 40-year-old guy who I'm bringing to the hospital now for ECMO. Well, if I bring him to the hospital, I'm probably going to put a mechanical device on because I only have 2 people on my team, and then it takes me 36 seconds to put the device on, and then so I've just decreased survival by 75% by doing that.
Yeah, it's kind of that's kind of what I was getting at.
So, I mean, to bring the team to the scene, you know, it would be easier to mobilize the team. France and Germany do it, but again, they just have a few cases.
They have a whole different system.
They have a whole
And they
different
have a
system.
system,
Right. Do you have a question?
Yeah, so a few things. First of all, Jose posted a great link that everybody should look at. It's the MCRIT article on hemodynamic directed dosing of epi, and basically the theme is we need to chill with the epi, maybe. But Bill was asking, are there any studies on double sequence cardioversion? Because like trying to cardiovert somebody out of AFib or a Y complex.
Bill from Kaiser Permanente.
Yeah. Because he's had a few refractory.
Thank you, California, for turning it.
He's had a few refractory like AFibs that he was trying to cardiovert, and ultimately the first, second, third time
Right.
weren't working.
Well,
We
we
consider two
all
vectors for that.
we all know that A-flutter is harder to cardiovert than AFib, right? That's more challenging. And you only need to cardiovert people who are truly hemodynamically unstable. And to me, hemodynamic instability is not measured by chest pain. That's silly. That's if you believe ACLS, and that's just crazy. It's if you're not perfusing your brain well. Like if you're altered, to me, it's time to shock somebody, right? Double sequence cardioversion. I mean, I think the answer is we have more data in how to cardiovert people than defibrillate people, because that's done on live people. That's a lot of EP lab studies, right? So we know this, because ideally we want to cardiovert people at the lowest amount that will work. But those are lower amounts of joules, so there's less damage to the myocardium than defibrillation. But I mean, sure, I guess you could. But I mean, if you're cardioverting, you have to go higher. You can give a poison at the same time, an antiarrhythmic at the same time you're giving cardioversion.
And
we know that
procainamide and it worked once, he says.
Yeah, and antiarrhythmics we know work well in people who have pulses and work terribly in people who don't have pulses, right? Yeah, procainamide is the comeback kid, right? So all the studies now, several studies now have said amiodarone's the wrong choice, and we also be using procainamide. The problem I'm having with putting procainamide back on the units is that there's a shortage of it. But right, so if you have a wide complex tachycardia, the answer is procainamide,
And the
not
dosing is
amiodarone.
17 mg per kg, so you're like, 80
Right.
mg.
So that max dose according to ACLS is totally made up. It's absurd, 17 milligrams per kilogram. People get more than that in the EP lab.
Right.
I mean, procainamide is roughly 750 to a gram over 20 to 30 minutes-ish, right? And that's how you get procainamide. And you watch out for, hypertension, QRS widening and stuff, et cetera, et cetera.
I guess also what you think the
What
double
disease does
sequence.
procainamide induce? What disease?
It's the Big L.
Because we used to give because procainamide is a 1A antiarrhythmic, right? So we used to give 1As to lots of diseases orally until we found it doesn't work. We used to have people who are from tons of ventricular activity, we used to give them tons of 1As. And then it stopped in 1989 with the CAST trials. So the drug that procainamide used to induce all the time was lupus. Procainamide induced lupus. What do you think?
I was saying, I think it's probably going to be hard to say to a patient, I'm hooking up to 2 defibrillators right now, or shock you with 2. I think there's just like maybe you'll scare them enough to get them out of the AFib. But if you think it's the vectors, you could probably just take the pads off and reposition them and try it again, just maybe in a different position.
And that's probably a Right, because it's probably the vectors, it's not the amount of joules, right? So that's a good point. And besides, what's wrong with some AFib in a pre-hospital setting or even
Yeah.
ER? Our job's not to convert people, our job is to rate control them,
Right.
right? Because eventually you'll get rate related ischemia. That's
Yeah.
why we have to treat you eventually. But most people will convert by themselves with no treatment. If you digitalize somebody and they convert, it's not because they did, just because you just got lucky, right? And most people, if you leave them alone and their left atrium is less than 4 centimeters, they'll convert spontaneously. If their left atrium is bigger than 4 centimeters, it's going to be hard to convert no matter what.
I mean, I remember the guy I took him pre-hospital, this was a couple of years ago. Call was for, he was on like a seizure or something like that, and we found him, he was in AFib, and he was brought to the hospital. This was during my residency. It was, I was riding on the ambulance, so I brought him in, and it was always nice, like during residency, to go to other hospitals and see how they would treat people. And the guy had a seizure, and he was in AFib, mentating fine, and then we get to the ER, and because of his blood pressure of 90, even though he's mentating well, they shock him out of the AFib. I was like kind of surprised that they did that. And like a young, healthy guy who just had a seizure, like give him a little bit of time, give him some fluids, he'll probably convert on his own.
So this is where ACLS gets it all wrong. They imply that if you're having chest pain, you need to be shocked.
And
no,
then,
wait, you are hemodynamically unstable if you can't perfuse your brain, right? And if you have chest pain or short of breath, I pick up poison and I'm not leaving the patient. I'm sitting there with him because your blood pressure may be 90,
right,
but
there's no emergency. Yeah, the guy's talking. But then I saw him a month later. I ran into him at a restaurant, and he's like, "I'm still having chest pain from the shock."
Right, from
and
the
he's
shock.
like, "And they didn't sedate me enough." He's like, "It really, really hurt. I'm still having pains from it a month later."
Right.
So it's just like, it's nice, it's cool, it's exciting, it's sexy to go press the button and hook them up, but we got to think about what we're doing to people, and is this really, like, does this really need to be done? And am I going to leave this guy with chest pain for the next month?
And if you ever see somebody who really gets electively cortiverted in the hospital, they have good sedation, right? And I mean, if we do it right, we have good sedation. But ketamine, fentanyl, whatever propofol, whatever you freaking want to use, but do something, right? Just make sure the patient's out of it.
Unless their ASCD goes off and they can't come home.
Right.
That's never fun to be in the room when that happens.
Right. But that's why they made magnets.
Right.
All right, that's good. What's the next article?
I could talk about this one because it's kind of right into this topic. It's a systematic review and meta-analysis from the Canadian Journal of Cardiology, recently in 2017, by Michelle Welsford.
Big deal. So we reviewed the last paper that came out, which was the first paper ever to look at this in a meta-analysis form by 8 studies. So now we have another one.
Right.
Okay.
And they basically are, they talk about before we get into kind of the paper and how many things they looked at, they obviously this is a big topic because of what we've just been talking about. These are difficult patients to treat, and it's still a big cause of mortality, and we can kind of make progress, but sometimes we can't kind of make it all the way back to walking out of the hospital and having a normal life. And they point out also to the work back in the 1990s showing that acute reperfusion of post-arrest patients, especially people that had ST elevations, improved outcomes. And they basically have been working on that. So this paper is specifically looking at, does early coronary angiography improve survival after out-of-hospital cardiac arrest? It's looking at all the papers and all the kind of current literature. So what did they do? They looked at all the usual databases. Let me go to the little chart that went through Medline and PubMed, EMBase, and Cochrane. They looked at even the trial registries, and especially the most important one, Google Scholar. That's an easy one to kind of delve into there. And they basically found 10,547 studies that they narrowed down toward the end of the day. They found 631 that kind of met the criteria, and when they read through those, they found that 23 would fit the criteria to be included in the study, and that could add to this discussion of, does this help or does this hurt? So they looked at these 23 studies, and the overall issue is that all of these studies are observational and cohort studies, so they're all low quality evidence. There's not really any big randomized controlled trials, which is part of the issue, but it's also a difficult population to do controlled randomized trials on, right? Cardiac arrest, they can't sign the waiver, and it's just difficult to kind of break away from many of the guidelines and governing bodies. It's just a difficult population to work with. But they did find these 20 or so studies that included 16,000 patients, so a decent N. It had these 16,000 patients had both ST elevation in ROSC, and also some that had no ST elevation on EKG after ROSC. All of them were cardiac arrest, but of every flavor, witnessed, unwitnessed, male, female, all ages, and it was essentially all comers. And the things that we were looking at was long-term survival, which was defined as 1 to 5 years. That was only talked about in 4 of the studies, and only about 1,500 or so of patients. And they also looked at short-term short-term survival, which was made it to the hospital, and they also kind of included in 30 days after that, whether they were in the hospital or out of the hospital. And then they also looked at a third subset of short-term with good neurologic survival. And there's more studies on that one because, of course, that's kind of the more important endpoint. It's not that do we make it to the hospital and they die an hour, 12 hours later, but can they walk out and have a normal life? That's the real success there, and not be committed to a facility or nursing home for severe anoxic brain injury for the rest of their life. So they looked at all these studies, and then they basically found that it does post cardiac arrest, immediate coronary angiography, and immediate was all the way up to 24 hours, so you could go right when you got to the ER, but because of the having to look at all the papers, they extended that definition to 24 hours. That was still considered immediate coronary angiography, and they had good outcomes. Let me see if I can find the actual specific numbers. In the let me see, page 12. They basically had, I'm trying to find the exact numbers. It had around a 50 to 60% improvement in survival, and around the same thing, an improvement of 69% in people that had survival. I'm actually trying to find that specific number of good neurologic outcome, which is right here. 52% had short-term good neurologic survival, and 69% in the group that got this early coronary angiography. And they kind of talk about the difficulty that this presents. This is kind of out of the realm of EMS and maybe a little bit more into the ER and the cardiologist, but this is kind of a difficult problem. Okay, this person has had a cardiac arrest. Now they come to the ER. They're still in ROSC, so we do an EKG, and they have ST elevation. The question is this ST elevation from a myocardial infarction, or is this from us beating on the chest for this CPR period? And then do we need to take them to the cath lab based on those findings? Or alternatively, another tool that ER physicians or cardiologists might use is troponins, specifically high sensitivity troponins. And should we use that? Well, troponins are terrible. I mean, that's the bottom line of this one. They have a sensitivity of only 65% and a specificity of only 66%. So we can't rely on troponins at all, which kind of makes sense, right? Was the heart leaking troponins from ischemic heart muscle because of the cardiac arrest, or because of this lesion that made this part of the heart ischemic? So that kind of makes intuitive sense.
And we know that 50% of tropes, less than 1, are non-cardiac
right.
In nature, and about 10%, less than 2, are non-cardiac.
And you're not going to make it through CPR and I'm sure a couple of shocks without leaking
right.
some troponins. That's just going to happen. But they also looked at people that had no ST elevation. So they've had a cardiac arrest, they got an EKG after and had no ST elevation. And they said, should these people go? But also, ST elevation, not having ST elevation also doesn't exclude coronary lesions. And that's one of the things that they looked at in many of these studies. There was, I think, 4 or so that looked at specifically that subgroup, and many of these people did have lesions. And
how many had lesions?
I'm gonna have to go and
that was that cardiologist who talked about
so,
this. His quote was 30% have
exactly, and that's what. So the acute culprit vessel was found in 80 to 96% of the ST elevation patients, ROSC that had ST elevation, and 24 to 33% of the non-ST elevation
that's
patients.
Exactly what he said. So this is
right.
a number we can quote. So if you have outopascal cardiac arrest with ROSC and you come into the ER and you don't have a STEMI and EKG, 30% will have a culprit lesion.
Right.
And do you go to the cath lab? And some people say, I'm not getting out of bed for 30% chance of a culprit lesion. Some people say 30% culprit lesion, I have to get out of bed.
Right.
It depends where you are and if you're fellows.
And so this study also did something really interesting that I thought. They reported the number needed to treat. Again, it's buried in here, and I should have highlighted it. But the number needed to treat for both ST elevation and non-ST elevation, they were slightly different. ST elevation, I believe, was around 5. So they needed to take 5 people to the cath lab to save 1 life and have a good neurologic outcome. And the number needed to treat for non-ST elevation was around 4. I think it was 4.1 or so. So again, like not that many, especially when we consider things like aspirin. And aspirin in people who are having strokes or people that are having heart attacks has a number needed to treat of 50. That's really good. Or aspirin that we use to prevent heart attack or stroke, so people that haven't had them before, that number is 1,600. So like these are really good number needs to treat. So should we be taking these people? The paper admits this is kind of low quality evidence because of the data we're pulling from, because it's a difficult population. But I think the answer is yes. To have a 30%.
So I know that you guys do it here, right? So here, we're in Newark right now. So here, if you have a cardiac arrest with no stim in the EKG, they're going to the cath lab, right? So when you were a resident, do they do that in your hospital? Josh, do they do yours? Alex, do they do yours?
In fact, people that had STEMIs, often the cardiologist would say, we got to wait and see how it plays out, because this could be just from the cardiac arrest.
I think it's also like because in the cath lab, a patient dies on a cath table, it dings against the physician.
Right.
So
that is definitely a reason.
People will say like, if you stabilize a patient, we'll take them.
But here's the question: how do you define immediate? Because if you have an out-of-hospital cardiac arrest with ROS, and you don't have a STEMI in your EKG, and it's midnight, and somebody says, "I'll take them at 7 in the morning," is that bad?
I think we don't know the answer. So this study, because of it had to pull from all these other observational studies, they had to expand their definition to 24 hours just to have enough data to even look at and come to a conclusion. And even they say their N is just not enough. So I think that this is a great example of why we need a randomized controlled trial. I think this should be at the top of the list for like the big associations, big groups that can fund these kinds of things.
I think there's one area where they have the two competing hospital systems have an agreement that out of hospital cardiac arrest, they put them on a mechanical device, and then they bring them to the hospital and they go straight to the cath lab. No questions asked. They don't need ROS, they don't need anything.
So we do know about 30% people have a culpable lesion. But we had that, the last meta-analysis we reviewed, I thought was 8 studies, and I thought that 7 were observational, 1 was randomized controlled trial. Maybe it was quasi-matching or something weird.
I can't recall.
Something weird.
I believe in this meta-analysis they say they had no randomized trial. Let me look at the actual.
But we all agree that, for our family, it's probably right to go to the cath lab, right?
I think,
and
just like
I hear these stories all the time about somebody with a trope of 80, and the cath was clean. So what happened? And the answer is the guy probably had myocarditis, right? Which mimics the STEMI on the EKG, right? And happens all the time. But how are you supposed to know that? You just have a patient with chest pain who's having whose trope is 80. That's all you know. And you go 80 trope is, the bigger the trope, the more muscle mass in general.
If we had a similar clinical entity, if you have right lower quadrant abdominal pain and 30% of the time it was appendicitis, we'd still scan that person every single time, right? So it becomes a kind of a different standard when we talk about, and admittedly it's interventional, you got to have a specialist and you have to have the right facility, so it's not as easy and simple as CAT scans, which are available.
Right.
But
for a CAT jockey, this is somebody who does this all the time, and the risk of dissection is exceedingly rare.
Right. And they have some good outcomes. And there's the Minnesota Research Consortium. They're kind of looking at this exact thing, although they add the component of ECMO and other things. But the core of it is quick early cath lab, and let's see how it plays out. And although they're still in the early stages, they're having good outcomes as well.
People tell me all the time, I'm on cath lab called 200 days after I'm 65. You want me to be on? You want me to come in now more than I'm coming in? How can I?
Well, right. Well, but I can understand that perspective is too, but
there's a tipping point where you go, it's just not worth it anymore to be paid,
or can I do this procedure safely because I just finished one and I'm getting called back in. Certainly that's a component, but I think that's where it comes to the system level of we need to have from a community or state or national level. Okay, let's say this person is not available, but this hospital is, and maybe that's how we can direct our EMS traffic.
30% chance for culprit lesion. 70% won't have it in cardiac arrest. The patient's still relatively unstable because they just coded. They have them on a cath lab table. They're getting some sort of anesthesia. I get it.
We do lots of.
If you're in person in private practice, it makes it very difficult. If you have 20 fellows, or you call once every 2 weeks. It's not so bad.
Certainly has to be, it's system dependent, because you need the resources to do this, but I think that's the idea. That should be the push. We should have the resources to have just like we would have an ER physician on for 8 or 10 or 12 hours. Maybe we need an interventionist on for 8 hours, and then they switch out, and understandably that's expensive
And it's
on
still
call,
so messed
but
up, and we have inner city hospitals in our state where people just say, I'll give up my STEMI patients, just call the guy who's on interventional. And other hospitals
Right.
who are in wealthier areas where the cardiologists compete, and they say, no way am I giving up my small percentage of STEMIs, small percentage of chest pain patients who are having STEMIs to any other competing group. You call us, and even if it's challenging to get a hold of us, you still call us for the STEMIs.
Right.
Well,
Right.
I mean, one of the places, kind of on switching out, one of the places that I worked when I was in residency, I mean, in the region, there was one cath lab center for about a 70-mile radius that had 24-hour cath. There were 8 cardiologists, all capable of performing interventional services. And when I would work at one of the other hospitals in the region that didn't have 24-hour cath, we had one that was from 8 a.m. to 5 p.m. We would do pretty much, if anyone needs a cath, call us. We have the capability. It was 2 cardiologists, and it was just the 2 of them. It was a community hospital. They didn't have, and I mean, they were just overworked. And if it's outside of those hours and those patients need cath, just send it to the other center that has 24-hour interventional capability. And essentially, that's kind of the agreement that was worked out between.
Were they both part of the same healthcare system?
No, completely separate healthcare systems, actually. There were other things later on that kind of changed that rather than going to the closer STEMI center, they wanted to go to a different hospital system that was much
We have
farther
75
away.
interventional cardiologists in our EMS system for the hospitals we go to. 75. It makes it very, very challenging. But they're never going to uniformly all agree about what to do with these patients. That's why the individual hospitals just have to. I mean, I guess it's the ER doc who just activates the cath lab team and calls it a STEMI when it's not a STEMI, because it's not STEMI. And
Right.
And you just go, if they take them, great. If they don't, it's not that terrible a thing based upon the science, even though science is swinging more toward taking them.
Right. I mean, looking at the long-term survival, so that's 1 to 5 years of the pooled group. So this is all comers that have ROSC. They had early coronary angiography was associated with 56% survival benefit versus not doing that early, less than 24 hours angiography. I mean, those are like big numbers
and
for.
you're talking about the early group was like 3.2, and the intermediate group was 5.4. So
Right.
So those are better than aspirin as our.
Yeah.
Well,
Those
it's
are
better-
good
it's
numbers.
Better than aspirin, it's better than your statin in your STEMI. It's better than your Lint in your STEMI. It's better,
I know. I mean, like, if you just think about like how much money, especially early on, did we spend on like seatbelt safety or other big public health campaigns, and I feel like this is in that
I mean,
realm.
listen, I mean, when somebody says to me, right, I agree. When somebody says to me, oh, should we heparinize the guys having a STEMI? I'm like, let the rest answer that question. I really don't care. I'm going to focus on getting the guy to the cath lab.
Right.
I'm going to focus on the call that goes to the interventionalist to make sure everybody is moving toward the cath lab. I'm focused on the operations.
Right.
It's just, I mean, nitro is over and over studied in STEMIs and does not help. Does not help. Yet people still give. In fact, it causes a steal syndrome. This is what Fuchs's been saying in signing for years. Titrating up your nitro and a STEMI is just craziness. They don't need it. Many cardiology fellowships around the world train no STEMI, no nitro for STEMIs. I don't give it. If somebody else wants to start it, that's fine. I've never given it in years and years. Right?
Right, and this is our realm. I mean, both the blend of ER, EMS, cardiac arrests, and I mean, for these patients, it's totally life or death. And we, early on, there's no way to know which one, and that's why.
Right. So we'll
we
keep
gotta
on
throw
calling
it.
this. We'll keep on calling these STEMIs if people don't have
I
STEMIs.
call and wake up the interventionalists.
Right.
Yeah,
And
I
I
mean,
think-
it's the right thing to do. My opinion.
I think especially in the community hospitals, which is something I'm obviously much more familiar with, I think it's the rapport and relationship you have with those cardiologists. If you're there full time and just say, hey, look, I know it's not a STEMI, but I think this patient really needs to go to the cath lab, and you're much more likely to get them rather than if you have never met them before, they have no idea what you're talking about, and you're trying to do something that's completely different to them. So
So maybe they have persistent hypertension. Maybe they'll do better with balloon pump for the extra half a liter per minute.
Yeah, which is the whole secret.
nothing special.
Yeah.
But maybe they get an Impala. Maybe they get something else. Maybe maybe a lot of stuff.
So I think
Right.
just
What do we have to offer? Silly drugs, heparin, aspirin, Plavix, Brilinta, silly drugs for for your plaque rupture.
And we as a fellowship do not think any drug is more superior or sillier than others.
Yes, sorry. So the 7,000 of you that are watching, right. We have no support between a 10A inhibitor or a direct thrombin inhibitor. Do you want to do the last one? We can do just in 2 minutes. Why don't we do the new stroke guidelines? Can we do that? Last 2 minutes. I know it's like 200 pages.
The Los Angeles Motor Stroke.
Oh yeah, let's do the Los Angeles Motor Stroke. Yeah. So I thought this was really cool. So if I don't get one freaking call a week from somebody, well, this was done by my buddy Mark Eckstein, who runs Los Angeles. So the if I get one call a week to talk about what's the best large vessel occlusion scale, right? And I'm still, after all of this time, and I just spoke to the state stroke committee too. After all this time, I still don't understand why you can't just. I mean, everybody should be doing this score in the back of a moving ambulance, not on scene. And number 2 is no matter what the score, you still need a CT head and you still need a CT angio. If your hospital's not doing a CT head, CT angio, and if your hospital's not doing a CT head or CT angio, and they're not doing a CT perfusion test if it's 6 hours or longer, you are behind the times, right? So we know that. And large vessel occlusion is obviously 2 things. It's your internal carotid or it's your cerebral artery. And we know from the Dawn study that these people should all be coded 24 hours. So we bumped it up from 6 hours to 24 hours for an acute STEMI, and we have better outcomes with mechanical thrombectomy up to 24 hours. So Dawn taught us that. So everything changed since stroke care 2 months ago. And all right, so who's doing this article?
So basically what this article looked at was the Los Angeles Motor Scale to identify large vessel occlusions. So to see, we discussed something similar a couple of weeks ago. Basically pre-hospitally, how do we know if someone is having a large vessel occlusion, and is that going to change where they are going to go to, whether it be a primary stroke center or a comprehensive stroke center. So the Los Angeles Motor Scale, it's a point system. There's 3 different things. There's facial droop, if it's there or not, it would be 0-1 arm drift, on a scale of 0 to 2, and then grip strength on a scale of 0 to 2. So what they did was, they had the Los Angeles Motor Scale was I guess a hospital, initially a hospital base, and they wanted to take it pre-hospital to see if they were able to extrapolate from that data who's going to have a large vessel occlusion. So they enrolled 94 patients into this study, and to get enrolled into this study, they had to it had to have been within 2 hours of the last known well time. They had a likely stroke indicated by a positive modified Los Angeles pre-hospital stroke screen, and so those, and then they also, and the people who they gave the data on were enrolled in the FastMag study, which is something else. So paramedics basically, they performed the LAMS, Los Angeles Motor Scale, and they also performed the GCS at the time of enrollment. And then when people got to the hospital, the study researchers, they did the NIH-SS stroke scale, they repeated the LAMS scale and GCS assessments, and then they also looked at a whole bunch of other different different ways of scoring stroke scales and different scales, and then kind of compared them all. It's a lot of stuff in this article. So they defined as they broke it down into extra large vessel occlusions, large vessel occlusions, and medium vessel occlusions. So the people that were analyzed were just those who had large vessel occlusions. So that was defined as internal carotid, the middle, the MCA and M1 or M2 segment, the vertebral artery, the basal artery, or posterior cerebellar or P1 segment. XLVO, extra large vessel occlusions, were the subset of LVO occlusions that are the largest. They're most proximal, most easily accessed. The ICA, M1, and vertebral and basal artery. And then MVO, if the arterial segments were inaccessible, in the middle, M3 or M4 posterior, P2 or higher, and anterior cerebral artery, A2 or higher.
So what they found was that among the 94 patients that were enrolled, they found that with a score of 4, basically there was a double the chance of having a large vessel occlusion, and then with a score of below 4, there was half chance of having a large vessel occlusion. Then, so other patients they found, so all the patients, so LVO was present in 45 out of 71, so 63%, and those included the ex-LVOs, and MVOs were present in 5 out of the 71%, and then there was a subset that had no occlusions. So the LVO patients of these 40, basically, so looking at these 45 patients and the cutoff of 4 is really what they kind of found. So people who had a cutoff of 4 with the showed the specificity of 0.73, sensitivity of 0.73, specificity of 0.71, and an accuracy of 0.72. So it was decent at finding the LVOs, and based on that, are we going to change our transport decisions if we're going to bring someone who has an LAMS score of 4 or above to a comprehensive stroke center versus a primary stroke center? So, I mean, I think that there is, this is good stuff to look at. One of the questions I had for the article is they're only enrolling people that have a last known well time of 2 hours or less, basically. And a lot of the people that we see, or around here at least, don't come in within the 2 hour window.
Because stroke 3 hours per is a wake up event, right?
Right.
STEMIs are not. So that's why they're totally different. And 2 hours. Yeah, I mean, so the accuracy is, what'd you say, 0.72? So the accuracy is 0.72. And maybe this one matters a little bit more since the Dawn study, right, where we're doing everything for stroke within 24 hours, not 6 hours anymore. And maybe this is only accurate if you're doing a CT head, CT angio, and CT perfusion, which we never used to do. On the other hand, if you tell me the score is 3 versus 4, I don't know what I'm going to say. Okay,
Right.
Still go to CAT scan. Still go to CAT scan.
Right.
Still go to CAT scan. I guess it's okay to document your baseline neurologic findings. So if people get better, we can say it's TIA, right? Which we've been TPAing a lot of TIAs anyway, right? And we know that when they get better from TPA, we know when they get better right away from TPA, it's definitely not because they're TPA. Because nobody in the NIH study got better from TPA immediately. They only got better a tiny bit at 3 months, and that's what we base all this on. So if they get better right away, it's because they're having TIA. I don't know. I mean, Josh, help me here.
Yeah, I don't know for sure. I don't know how generalizable this is at this point. I don't know if I would, like you said, if someone has a 3 versus a 4.
So if you live in a state where it's important to predict large vessel occlusion because you're going to bypass a primary stroke center for a comprehensive stroke center, if you live in that kind of state, which some people have, right? Because most of the world isn't like New York or California. It's in between, where you may only have one comprehensive stroke center. And if your comprehensive stroke center is 20 more minutes away, and you're bypassing your primary stroke center, and you're not, and now that the window's up to 24 hours,
right?
Like,
And that's
you
the
could
other
argue
thing.
just go to the comprehensive because it's not the large vessel occlusion is not a perfect test, but all these scales are not perfect anyway. Just drive the 20 minutes. So to me, all this says is every system should be judged individually.
Yeah.
You can't make judgments based upon this. And in states like ours, where we're not bypassing primary stroke centers, go to comprehensive, I don't know that any of this matters, right?
Right. And then I guess on the flip side also, let's say you have to drive an hour to the next hospital and you're only at 2 hours. You can say, all right, I'll at least get the workup started at the closer hospital. I have 24 hours to go do a thrombectomy, so it doesn't really matter if I go to the closer hospital.
Except that I would venture to guess that earlier mechanical thrombectomy is better. So
yeah.
Probably it's 7 hours versus 8 hours. And my guess is we'll never have a sample size large enough to prove that. but it just seems fundamentally to be the right thing.
Yeah.
You know,
But what do you do? Yeah, and then what do you do with the person who's at the 3-hour window or getting close to the 4.5-hour window? Depends on if you believe in TPA or not. Now, do you go to a further place where you're going to be out of the window for TPA, but you're at a center that can do? Yeah.
and even if you're really smart and really good at doing one of these scores to figure out large vessel occlusion, the scoring is not that good.
Right.
And the worst thing you can do is be sitting on scene to do this.
These things are so subjective. I mean, what's a grip strength? Like, what are you judging this based
You're
on?
aphasic and you're not
And you're in the
moving
back
well,
of an
it's-
ambulance, and this is something that's happening. What's fast arm drift versus slow arm drift? Like,
Right.
how are we? Like, this is so subjective.
Right.
All these measures. So, I mean, how am I going to go train, 100 paramedics to give me the same exact score? I just don't think
Right.
that is so feasible.
But would I support bypassing a primary stroke center for comprehensive stroke center if you had another 30 minutes to drive? I would.
Yeah.
Because being in that 30-minute different window is, now that we're 24 hours as opposed to 3 or 4.5 hours, it's just not gonna, you're never gonna
Right.
you're never gonna find somebody at 23.5 hours.
Right.
Exactly. So why not go to a comprehensive
Yeah, I
center?
think if you can get better, a higher level of care, a little bit further, and you can get the patient there safely, I think it makes sense to go to the.
But if this
But-
comprehensive is 3 hours away, I would say go to the primary and be flown to a comprehensive if you have something on your CT perfusion or CT angio which shows a clear lesion in your middle cerebral artery or your internal carotid. And good luck trying to figure that out in the pre-hospital center.
I think that's the issue. Does the scoring help us? I'm not sure that the scoring help us. If you have tingling in your arm, are we going to drive 5 hours to a comprehensive? Not necessarily. If you had a prior stroke
Right,
and now you
that's a
have
good point too,
a
yeah.
big facial droop, you're aphasic, and you can't move your right side of your body, well, that's like that you don't need a score system for that. Of course, I also think it's very interesting that in their data set of their 94 patients, 41% of them reported any alcohol use. I can't imagine they included people in their study who were drunk, so I think it goes to show that it's hard to predict what is going on exactly in the field. If they have an obvious big stroke, yes, you should be bypassing probably. If it's something else, maybe you just got to get them there and need more information.
Right.
But being the
this
CT.
Was, this was, what's his name, Dave Schrager. This was a study in JAMA several years ago. We showed 26% of people who get brought to the ER with a stroke are not a stroke. 26%. So that means, and these were in big hospitals, tertiary care centers. Some of them had, some of them had MS. Some of them had a UTI. And how is it that smart academic people can screw up a stroke for UTI? And the answer is, if you do it enough in the heat of battle, this will eventually. I remember when I was a resident on neuroservice, we had people admitted with UTIs, and we go, "How could this have happened?" The answer is, you've never worked in an ER where you have a million patients and you're going crazy, and every now and then, a UTI will slip past you.
Right. My very last stroke patient, I was called over because they were rushing them to CT. EMS thought they were a stroke. The nursing triage person who met them thought they were a stroke. I looked at them, I said, this doesn't look right. Number one, they're not breathing, so we're going to fix that first. And then number two, let's check a blood sugar because that somehow got missed along the way. Blood sugar is greater than 600, and it turned out to be DKA, causing their ultramental knot. And they're looking over there because they have a stroke because they're not awake and there's no blood to the brain.
When we do a CAT scan, some of the people have encephalomalacia.
Right, there's not many things.
It's not so straightforward.
Many
And if
things.
you've ever been part of a big academic institution where you sat with a radiologist and he's like, I'm just not sure if this is blood, let me just go ask the neuroradiologist. And you say, well, if you have to ask the neuroradiologist, how am I going to be at interpreting a CAT scan in the middle of the night, right? Which is what many ERs have to do. The ER doctor interprets the CT. So that just goes to show you there are these subtle things that you really want to give TPA to somebody with maybe a tiny bit of blood. And we all know that, although everybody quotes this number, that 6.1% of people who get TPA for a stroke will bleed, that was based upon the NINDS trial many years ago, and all the community hospital studies, like the big one in Cleveland, so it's more like 15%. And you do have worse outcome if you're bleeding from TPA than if you just have bleeding in your brain from TPA. So it's a clear risk. But I do think mechanical thrombectomy is the answer in the future. I just don't know how you get enough interventional neurologists in the world to do this 24/7. That's not going to happen. All right. Anything else with that? That's good. So I don't know. To me, I mean, any type of scale is fine. It has to be simple. Whatever simple and works in your system. I don't think we all have to use the same score, but something simple is what's really needed. And the message of number one has to be: never do this on the scene. Do this in the back of a moving ambulance. Go into the hospital. Because no matter what your answer is when you get to the hospital, the truth is the doctor probably just doesn't care, because he has to get the patient into CAT scan. He just needs to make sure the patient doesn't need to be intubated, and they don't have something terrible else going on, and then get them into CAT scan. And if your hospital's not doing the CT angio right after the CT head, they're doing the wrong thing.
And these scores are designed to be done on a stretcher specifically.
Yeah. So, all right. Well, why don't we stop? So, what's coming up, Mike? Let me see. So, sign up for the EMS dinner, which is May 22nd.
Tuesday.
Tuesday of EMS week, May 22nd. 30 great speakers will be at the Robert Judah Hotel in Newark. Sign up via our website. We're trying to get hundreds and hundreds of people there. And then anything else coming up? We'll see some people at the all New York City and all New York and all New Jersey EM conferences. And then I know we have a date to go to Lehigh Valley Hospital in March sometime. And that's it. We will be at Monarch Education next week, Wednesday at 1 o'clock till about 3:30. Thanks for tuning in.